Immunitas in Latin means freedom from public service. This is a privilege, a special honor for highly regarded individuals, exempting from the usual burdens of citizenship in Rome, such as taxes and military service. In the medicine, immunitas means the privilege to be protected. Immunity or defense mechanisms may be specific or non-specific. The non-specific mechanisms are innate. They include the physical barriers, surface flushing, tears for example, the mucosal secretion, antibacterial agents such as pH elevation or lysozyme, commensal microorganisms, phagocytic cells, inflammatory responses, including inflammatory mediators, destruction by phagocytosis of cells, destruction by the complement cascade, in C-reactive protein release, and also fever, blocking the mitosis and the inhibition of the growth of some microorganisms, and also increase phagocytosis. The specific immunity, the adaptive immunity, is acquired. It presents with four main characteristics. First, recognition, the capacity to recognize a microorganism or agent, as here. Learning, more effective response to second and subsequent exposure to the same agent. Memory, long-term retention of the improved response. And finally, self-discrimination, capacity to discriminate between own body components and foreign substances, and to direct its attack only against intruders, also against abnormal cells of the body, tumor cells, or those harboring viruses. The specific immunity system works in collaboration with the non-specific immunity system to focus and reinforce non-specific defenses. Let's now consider the components of the specific immunity system. It includes T lymphocytes. T lymphocytes, their maturation is thymus dependent. They express T cell receptors, and also they present under the form of clones, populations of T cells bearing a unique T cell receptor. Antigenic determinants, the epitopes, are characterizing the antigens or immunogens, anything the specific immune system is able to recognize and to which it responds. Epitopes represents parts of the agent or the microbe with which the T cell receptor can bind. The self-tolerance, the clonal receptor for self-antigens, are eliminated or suppressed during the maturation in the thymus. B lymphocytes, maturation in the red bone marrow and production of antibodies. This is their role. The antibodies represent a Y-shaped protein molecules with some characteristics. FAB, fragment antibody. This is unique for a clone antigen binding fragment analogous to the T cell receptor binding site, attachment to and marking of foreign epitopes. FC portion. This is the crystallizable fragment common to a class of antibodies. It ensures the attachment to the FC receptors of macrophages, as shown here, to the macrophages. Also to polymorphonuclear cells, and ensure the transportation to tissue where invading agents are present, binding to the agents, antigens, and phagocytosis and cytotoxicity release of inflammation mediators. for example, binding to platelets, mast cell complement. The classes of antibodies are 5. Immunoglobulin M group. These are the first produced in immune response by an activated clone of B cells. Immunoglobulin G, IgG. This is the principal immunoglobulin circulating in the blood. Immunoglobulin E, involved in antigen triggering of mast cells. The clinical significance of this immunoglobulin, this is the allergic and parasitic helmintic diseases. Immunoglobulin A, this is the secreted antibody in the saliva, into the breast milk, and also in mucosal secretion. And finally, immunoglobulin D serves as an antigen receptor on lymphocyte membranes. The 5 types represent the first line of protection along with the non-specific defenses. They are collectively named gamma globulins. The third population cells, known also as non-B, non-T or null cells, they are 2 types. Natural killer cells with natural killer cytotoxic activity. Natural killer. In the control of tumor development, they recognize cells that is becoming abnormal, then engage and to destroy the target cell, the tumor cell, for example. Or antibody-mediated cellular cytotoxicity in autoimmune disease. These lymphocytes possess numerous Fc receptors attached to cells covered with an antibody and kill it. This slide illustrates the function of natural killer cells attacking the surface of the tumor or virus-infected target cells, damaging the membrane and destroying the target cell, or the killer cells combining with antibodies on the target cells, binding to Fc receptors and destroying the cells. Another component of the immune response, this is the major histocompatibility complex. They represent polymorphic cell surface proteins involved in the rejection or acceptance of transplanted tissue. 4 elements of the immune system, for example antigens on the surface of leukocytes, they are known also as HLA system, human leukocyte antigens. MHC present as 2 classes. MHC class 1 molecules involved in the procession of endogenously synthesized viral, for example, proteins. Association viral antigen plus MHC1 activates the cytotoxic T cells, expressed by all somatic cells, the MHC class 1, all somatic cells, while the MHC class 2 structures are expressed only by the specialized antigen-presenting cells, as shown here. Macrophages in tissues, monocytes in the blood, Kupffer cells in the liver, microglial cells in the brain, and also resident macrophages in the spleen and lymph nodes. Various non-phagocytic cells, for example, dendritic cells into the skin and cells into the lymphoid tissues, may also present MHC class 2 structures. The MHC protein is responsible for the management of the antigen internalized, the extraction of the epitope of the immunogenic section of the antigen, and expressing on the surface, thus presenting the antigenic determinant to the immune competent cells of our organism. Let's now present the main characteristics of the immune response. The role of the immune response is to discriminate between self and non-self and to eliminate the foreign substances. The first stage, this is the antigen processing and presentation. After the internalization of the foreign substance, as already shown on the previous picture, modification of the structure and extraction of the antigenic fragments in associate with MHC class II molecules. In the next step, there is a lymphocytic recognition and activation. The recognition is achieved by specialized T lymphocytes, T helper cells. They represent CD4 lymphocytes in association with MHC molecules class II. This is here shown. T helper CD8 lymphocyte in association with MHC molecules class I are also involved. The activation includes two signals. First, binding of the antigen-specific T lymphocytic receptor to the antigen, as shown here, binding to the antigen. And second, release of interleukin-1 from the antigen-presenting cell, macrophage interdigitating dendritic cell. These two signals induce the expression of interleukin-2 receptors on the surface of the CD4 cells. Also, cytokines are produced by the activated cells. There are two types of immune response: cellular immune response or humoral immune response. In cellular immune response, an activation of cytotoxic T lymphocytes is achieved through the influence of two signals: binding to the MHC class I antigen complex, here shown, and also following stimulation by interleukin-2 released by the T helper cells type 1. As a consequence, a release of substances, cytotoxins from the activated cytotoxic cell, will kill an infected target cell harboring viruses or eventually foreign tissues. This is the cytotoxic effect of the cytotoxic T cell, the cell humoral response. The humoral immune response includes activation of B lymphocytes by the cytokines released by the T helper cells, type 2, activated by the interdigitating dendritic cell shown here. The stimulatory effect of the T helper cells is realized through the release of interleukins 4, 5, and 6. So, this will stimulate the B cells to proliferate, to differentiate into high-rate antibody-producing cells, plasma cells. Plasma cells are short-lived. They are living 5 to 7 days, but they are producing about 2,000 antibodies per second during that time. In addition, B cells differentiate to form memory cells. These cells will respond more rapidly and efficiently to subsequent encounters with identical or closely related antigenic structure. This slide illustrates with more details the two components of the immune response, the cell response and the humoral response. Let's now discuss the immune disorders. They present under the form of three big groups. First, hypersensitivity states or allergies. Second, autoimmunity disorders. And third, deficiency states. Let's start with the allergies, hypersensitivities. They present as immune responses in which the antigen is an environmental agent, food or drug that is not intrinsically harmful. Let me introduce the term atopy. This term is used to describe allergic conditions that have a familial predisposition, a genetic component. Four types of hypersensitivities exist. They are presented here. Type 1, immediate hypersensitivity. Type 1, anaphylaxis. Type 2, cytotoxic. Type 3, immune complex mediated. All these are antibody mediated and more rapid. The fourth type is cell-mediated and delayed. Let's now consider one by one these abnormalities. The type 1 hypersensitivity, the anaphylactic type, it is mediated by immunoglobulin E, antibodies bound to the mast cells and also in some occasions to basophils. Antibodies are formed in response to a particular antigen known as allergen. This is here. Under normal circumstances, immunoglobulin A probably functions to protect against parasitic infections. Thus, at the first presentation, this is the sensitization phase, the antigen-presenting cells are presenting the epitope on the surface and to bind to the Th cell receptor, as already discussed. A humoral immune response is induced and B cells will produce a lot of antibodies, antibody IgE. The IgE antibody will bind to the mast cell surface. Thus, the first presentation of the antigen, the allergen, prepares a sensitized mast cell subpopulation. The second presentation, this is already generating a hypersensitivity reaction, results from the binding of the antigen to the antibodies fixed on the surface of the mast cell. Thus, the mast cell will be activated to release the content of the granules by degranulation outside the cells. At some occasions, the degranulation of mast cell may be produced by complement fragments C3a and C5a. They are known as anaphylatoxins by some drugs such as morphine or codeine and venom, B-venom. Thus, a rapid initial response is released due to the degranulation of granules with stored preformed mediators. Usually, this response is evident 5 to 30 minutes after the re-exposure, with resolution within 30 more minutes. There is one more phase, second delayed phase, sets in 2 to 8 hours later, even without additional antigenic challenge, and it lasts for days. It causes intensive infiltration by inflammatory cells and tissue damage. This is the mechanism of allergic rhinitis, allergic asthma, and acute drug allergic reactions. This slide illustrates the primary mast cell mediators, the rapid response. Biogenic amines such as histamine are released. Histamine exerts a profound effect on bronchi in asthma. For example, histamine causes smooth muscle contractions in the bronchial smooth muscles. It increases the vascular permeability and causes increased mucus production. Also, chemotactic mediators are produced and some enzymes. For example, hemase tryptase. Sometimes proteoglycans such as heparin are also produced and released. The secondary, the delayed response, it includes the release of other mediators derived from the membrane, lipid mediators. For example, leukotrienes. Leukotriene B4 exerts a powerful chemotactic effect. Other leukotrienes increase the vascular permeability. They excite the smooth muscles of the bronchi, bronchoconstriction, and increase the mucus gland secretion. Also, prostaglandins are produced. They contribute to the vasodilation and mucus secretion and also potentiate the bronchospasm. Platelet activating factor is also produced, causing platelet aggregation and potentiating the histamine effects. Collectively, all these mediators produce the following effect: vasodilation, increased vascular permeability, smooth muscle spasm, and chemotaxis and recruitment of inflammatory cells. The anaphylactic reaction presents under two forms: local anaphylaxis, atopic allergies, the local response, type 1, to inhaled or ingested allergens, urticaria, angioedema, rhinitis, asthma. The other type of response, this is a systemic anaphylaxis, typically follows parenteral or oral administration of allergens. It demonstrates with erythema, pruritus, itching, urticaria, bronchoconstriction, and laryngeal edema. Also pulmonary edema and hemorrhage because of the increased vascular permeability. Sometimes it may complicate with right ventricular dilatation and pulmonary vasoconstriction. This slide summarizes the hypersensitivity type 1 reaction in asthma. This is the allergen of pollen interacting with T helper cells to stimulate immune response, synthesis of antibodies, binding to the mast cells, causing release of interleukins, recruitment of eosinophils, and also preparing the sensitization reaction. Next exposure of pollen will allow the antigen determinant to bind to the antibodies covering the surface of the sensitized mast cell. As a consequence, release of mediators from the mast cell will cause the following effects: vasodilation and increased permeability and edema, eosinophil recruitment, and mucus overproduction. This is here the appearance of the normal airway and the airway under the effect of multiple exposures to allergens. As we see, the edema will cause the thickening of the lotus to decrease the lumen. Also, hypertrophy of the muscle layer also contributes to the thickening and to the decreased lumen. Also, hypertrophy of the mucous gland. They are stimulated to multiply, and the plugs of mucus also contribute for the significant narrowing. This is an obstructive disorder, the asthma. If you compare the normal lumen with this one, it is easy to evaluate how powerful is the obstructive effect of the hypersensitivity reaction. Now, the type 2 hypersensitivity, the cytotoxic hypersensitivity. It is mediated by antibodies, IgG, sometimes by IgM. These are the antibodies. First exposure to antigen produces a sensitization and the selection of a clone of B lymphocyte with transformation, later amplification and differentiation to produce plasma cell. This is the humoral immune response, and production of the specific antibodies, IgG or IgM. Now the organism is already sensitized. The next exposure will produce the hypersensitivity reaction, which is the important detail. Antigens in these reactions are localized on cell surfaces. So antibodies will bind to form antigen-antibodies complex on the surface of the cells. It is important to know that the formation or a deposition of an immune complex, antigen-antibody complex, always activates the complement system. The complement-dependent reactions are as follows. First, direct lysis of the cell because of formation of C5b-9 complex. This is the membrane attack complex, MAC. Or opsonization, thus producing stimulation of the phagocytosis. In addition, antibody-dependent cell-mediated cytotoxicity of null or killer cells, an additional factor for the lysis. This is illustrated on the picture. Please note this is an error, not anaphylactic. This is an error. Cytotoxic. Activation of the complement, the opsonization, the membrane attack complex formation, activation of the cytotoxic cell. All these effects will destroy the cells. Which are the diseases generated by this mechanism? As an example, for example, transfusion reactions, erythroblastosis fetalis, hemolytic anemias, especially autoimmune anemias. Some drug reactions are also achieved in the same way. Now the hypersensitivity type 3, immune complex mediated hypersensitivity. It is mediated by antigen-antibody complexes, immunoglobulin G and IgM. Let me know that formation of immune complexes is a normal event, and usually they are normally cleared in the circulation by the phagocytic system. The complex deposition may be achieved in capillary and arterial walls, thus to cause local inflammatory changes due to the tissue injury, vasculitis. Again, let's review the mechanism. The first exposure, sensitization, selection of B lymphocyte clone, primary transformation, plasma cell generation, humoral immune response, and production of the antibodies, IgG and IgM. The second or prolonged exposure of the antigen will produce the secondary immune response. The specific antibody is released and will bind to form the complexes, antigen-antibody complex. These complexes will circulate into the blood in the systemic form of the reaction, or may be deposited on a site of antigen entry, the local form. Immune complex deposition in tissue, as already known, is activating the complement system. Acute inflammation is immediately produced, mediated by C3a and C5a components of the complement. They are powerful inflammatory mediators, and also necrosis due to cell necrosis, tissue damage, mediated by the formation of the membrane attack complex, the MAC, formed by C5b to 9 components of the complement. The systemic immune complex disease may demonstrate under the form of serum sickness. Serum sickness, this is a disorder observed after administration of large amount of foreign serum in the past to treat infection disease. Because of formation of immune complexes, antibodies are produced against the foreign proteins. The deposition of these complexes in the vessels will cause vasculitis. Deposition locally into an organ will cause the so-called Arthus reaction, localized tissue vasculitis and necrosis because of the focal formation and deposition of immune complexes. There is a planting of antigen within a particular tissue, for example, into the kidney, into the renal glomeruli. Again, the mechanism includes the complement activation and activation of other inflammatory systems such as coagulation cascade and platelet aggregation. This local complex disease also is characterized by necrosis, fibrinoid necrosis. This slide illustrates the steps into the immune complex hypersensitivity. The antibody and antigen present into the blood, formation of complexes, and deposition of the complexes on the surface of the endothelium with activating of platelets, release of histamine and serotonin, release of chemotactic and activation factor for neutrophils, degranulation of basophils, and finally, destruction of the vascular wall. This is called fibrinoid necrosis due to the activation of the complement system and release of inflammatory mediators. This is an illustration of typical fibrinoid necrosis into the vessels. So, don't forget the most common consequence of immune complex disease. This is the deposition of immune complexes and inflammatory changes in small vessels, generalized vasculitis. Now, the fourth type, cell-mediated hypersensitivity. It is initiated by specifically sensitized lymphocytes. Antibodies are not playing here the major role. This is the first exposure, the selection of specific lymphocyte clone, the amplification, and the production of effector cytotoxic cells. During the prolonged exposure or repeated exposure, lymphocytes will be activated and recruited, to release lymphokines to exert direct cytotoxicity and lysis of the cells attacked, thus to cause tissue necrosis and chronic inflammatory reaction. The inflammation especially is potentiated by the macrophage activation by the lymphokine release from the activated T cells. This is here the combined picture of the type 4. The presentation of the antigen, activation of the immune response, mobilization of lymphocytes, exerting direct killing of cells of the intruder or activating the macrophages, thus causing necrosis and inflammatory changes. This is an example typically of granulomatous formation inflammation. The contact dermatitis is produced in such way. The transplant rejection in transplanted patients is also achieved by the same reaction. Type 4 cell-mediated hypersensitivity reaction. The type 4 hypersensitivity reaction, this is the typical response to Mycobacterium tuberculosis, to fungi and protozoal invasion, to some parasites, in addition to the graft rejection and the contact dermatitis. The next group of immune disorders includes defective immune responses, autoimmune response. The autoimmune response results from breakdown in self-tolerance. The self-tolerance, this is the lack of response to one's own antigens. The cause for the lack of tolerance may be various. For example, clonal deletion defect. The self-tolerance is due to normal clonal deletion of cells expressing ability to produce antibodies against own antigens. So, the defect of clonal deletion will produce normal B cells with surface immunoglobulin against self-antigens, against DNA, against myelin, collagen, thyroglobulin. Or the clonal anergy defect, irreversibly functional inactivation of developing T and B cells. The recognition of antigen is achieved in the absence of antigen-presenting cells. Another mechanism of autoimmunity is the defective suppression of autoreactive lymphocytes, or bypass of helper T cell tolerance. Thus, it may be bypassed by some organisms eliciting antibodies that cross-react with host antigens, or direct T cell dependent polyclonal B cell activation, for example, by Epstein-Barr virus. Sometimes imbalance of suppressor to helper T cell function may cause loss of suppressor T cell effect. And finally, another mechanism to produce autoimmune response, this is the emergence of previously sequestrated antigens which therefore did not induce tolerance during development. For example, the sperm or the myelin basic protein. Let me note that the autoimmune response demonstrates a genetic component, a predisposition to autoimmune diseases. The forms may be tissue-specific, for example, thyroiditis or systemic. This slide illustrates the damage to the thyroid gland by a tissue-specific autoimmune reaction. The deposition of lymphocyte and destruction of the tissue of the thyroid gland. The systemic lupus erythematosus is a good example for the systemic autoimmune reaction. The cause is not yet elucidated. It is believed to be idiopathic loss of self-tolerance with autoantibody formation. Antibodies are anti-nuclear antibodies against native DNA or against the ribonucleoprotein, the so-called Smith antigen. Anti-nuclear antibodies need one more impact, cell damage, because the antibodies cannot penetrate intact cells. In addition, some antibodies against blood elements, blood cells, are also present. The pathogenesis includes basic defect in the maintenance of cell tolerance, such as proliferation defect of the B cells and helper T cells hyperreactivity. Now, as a consequence of excessive formation of autoantibodies, immune complex deposition is achieved. Where are the complexes deposited? They are deposited in small vessels, blood vessels, to cause generalized vasculitis with necrosis and some secondary effect in some organs, such as myocardium. Into the skin, the deposition will cause localized change, hair loss, and erythema because of inflammation due to the deposition of immune complex and activation of the complement system. Into the CNS, the deposition will cause local changes related to disorders such as seizures and psychosis, and into the kidney, glomerulonephritis is produced due to the generation of inflammatory response after the deposition of the complexes antigen antibody. So, proteinuria and erythrocyturia will be observed into the urine. Some other examples of autoimmune disorders are, for example, Sjögren's syndrome, an immune-mediated lacrimal and salivary gland destruction because of presence of anti-nuclear antibodies against ribonucleoproteins. Another example, this is the systemic sclerosis, scleroderma. Again, it is produced by some defect in cytokine productions and diffuse localized fibroblast activation. The third class of immune disorders are the immunologic deficiency syndromes. They may present as primary forms, usually hereditary, typically manifesting between 6 months to 2 years of life because of maternal antibody production loss. They are due to defective steps in the antibodies production. This is here a schematic presentation. Every step may be damaged. The ligand receptor interaction, the signal transduction, the recombination, or the cellular metabolism in immune competent cells responsible for the production of antibodies. In Bruton's disease, there is a lack of mature B cells as shown on this slide. At the same time, T cells are normally present into the lymph node, while the areas populated by B cells are empty, absent zones filled with this type of leukocytes. This is due to a mutation in a tyrosine kinase gene, and usually the germinative centers are absent in lymph nodes, also in the spleen, while in bone marrow precursor of B cells may be present in normal numbers. As a consequence of the lack of B cells, plasma cells are also absent from all tissues. Let me note, because of the presence of T cell number and functions are entirely normal. Which is the problem of these patients? The disease presents as recurrent bacterial infection, beginning usually at the age of 8-9 months of age, caused by Staphylococci, Haemophilus influenzae most commonly. There is virtually no serum immunoglobulin G, but cell-mediated immune function is normal, so viral infections and fungal infections are handled appropriately. So this patient will die as a consequence of a bacterial infection. Another primary disorder, this is the DiGeorge syndrome, thymic hypoplasia or aplasia. It is characterized by presence of B cells while the T cells are absent. Absent T cell zone and B cell are present. So there is a lack of cell-mediated response, especially to viruses and fungi, while the serum immunoglobulins are normal. So, which is the defect? An almost normal handling of bacterial infections and severe complications due to fungi or viral infections. The most severe primary form, this is the so-called severe combined immunodeficiency disorder. It combines lack of both T and B cell zone. They are empty, a combined deficiency, which is the consequence. No cell immune response, no humoral immune response. These children are vulnerable to both bacterial and viral infections. These patients will usually die within 1 year by an infection. Another primary disease, immunodeficiency disease, these are examples of genetic deficiency of the complement system. They may be present for all complement components and for 2 inhibitors. Based on the central role of the C3 component, genetic defect in C3 will increase the susceptibility to bacterial infections. C2 and C4 deficiencies are related to increased risk of immune complex mediated diseases. Finally, we'll discuss the acquired immune deficiency syndrome. It is caused by the human immunodeficiency virus, HIV. It causes the disease by reproduction in a host cell using its genetic and metabolic machinery. This is here the distribution throughout the world. As you can see, it originates from Africa. This is an African virus with significantly less cases in other portions of the world. This is a schematic presentation of the structure of HIV virus particle. Let me stress on the presence of some important components. Glycoprotein 120, a surface protein with an affinity to the CD4 component of the helper T cells. The CD4 component is present also in glial cells. So, this surface protein allows the virus to bind to helper cells and to glial cells into the CNS. Glycoprotein 41, it is bound to the glycoprotein 120. The exposure of this molecule after binding, this is here binding of the glycoprotein 120 to the CD4. This is the complete binding. Exposure of the glycoprotein 41 allows the fusion of this peptide into the cell, into the host cell, the T cell. So, viral RNA will penetrate into the cell. This is here the mechanism of the viral penetration in the host cell presented. Viral glycoprotein is 120, binding to the T helpers. Viral glycoprotein 41 exposed, passage into the interior, and RNA codes for viral DNA synthesis. How is it possible? It is possible due to the presence in the virus of a specific enzyme, reverse transcriptase. This is the weapon of the virus, allowing it to reproduce into the host cell. Thus, the virus RNA will code for viral DNA synthesis and to start the formation of provirus emerging with host DNA. This is mediated by the viral reverse transcriptase, and it can be blocked by a medicine known as azidotimidine, AZT. Azidotimidine is used now to cure, less or more successfully, the AIDS. Provirus forms and merges within host DNA. So the host DNA will be engaged to produce viral constituents, including polyproteins, packaging them on the cell surface, and as a consequence, new virus synthesis. This may be again blocked by protease inhibitors. New viral synthesis finally will cause destruction of the host cell and release of new virus particles. Thus, repetition of infection sequence will allow the virus to invade more and more T helper cells. The process described is not so rapid. Usually, the virus, after penetrating the human organism, remain dormant, latent, for years, 5 to 10 years. Now, the pathogenesis of changes induced by the viral growth into the organism. The main consequence is the reduced T helper cell numbers because they are destroyed to release the virions. This will cause deficiency of cellular immunity, humoral immunity also to impair inflammatory responses, and as a consequence to favorize the impaired cellular immunity favorizes tumor growth, while antibody production impairment will potentiate other complications especially complement-mediated toxicity, to increase the rate and severity of infections in the body. This slide summarizes the role of the T helper cells in immune responses and inflammatory responses. The production of cytokines, especially interleukin-2, necessary to activate other cells, lymphocytes, killer cells, macrophages. So the release of these factors will be compromised, decreased, and thus will produce defective, deficient immune responses. Now, the outcome of the infection. After the initial infection, there is a latent period followed by an acute phase. This is the phase in which the patient becomes seropositive. The glycoprotein 120 is present into the blood. In acute phase, just minor flu-like picture with possible CNS signs is present. Later it will progress to the chronic phase to include the lymph system, lymphadenopathy with failure of the Th cell count because of the progressive destruction of Th cells and generation of variant particles. This is followed by the crisis phase, demonstrated with long-term fever, weight loss, diarrhea, and severe Th cell losses, with consequences typically persistent infections, viral infections, fungal infections, yeast infection. This is known as AIDS-related complex. It will complicate later by extremely severe infections, tumors, and CNS involvement. Let me note especially the presence of the so-called opportunistic infections. These infections are caused by microorganisms normally residing in our body with no effect, because the immune system is protecting the organism against these microorganisms. However, in the immunocompromised patient, these microorganisms will easily produce infections. For example, the pneumonia produced by Pneumocystis carinii. Half of deaths in AIDS patients are due to pneumonia caused by Pneumocystis carinii. Malignancies are often complicating. This is here an example of Kaposi sarcoma, skin sarcoma, in an AIDS patient. Because of the suppression of cell immunity, the malignancies are growing rapidly and frequently in these patients. This slide illustrates the dynamics of the disorder. The first 5 years, a negative window with no sign of disease, except the flu-like illness. And later, antigenemia, the HIV antibody, and after the 5th year, the AIDS-related complex and AIDS complication about 10 years after the infection. The prognosis is very poor. The treatment is not yet so successful. As already mentioned, blocking of the reverse transcriptase or other enzymes, protease inhibitors, are used with either changing or small success. The successful treatment of the AIDS remains to be discovered.